I'd like to welcome Marion Kainer, and you and I go back a very long time, back to our registrar days at St Vincent's Hospital. And Marion actually did a training, ID training in Melbourne, and we worked at kids, and then took on a very exciting role over with the CDC. And then she stayed in the US and went on to have a very prominent role with the Tennessee Department of Health, but also was integral in working with the Obama administration to highlight the areas around AMR and also antimicrobial stewardship. So she's particularly interested in what we do because I think she's been watching us very closely. And for those of you who don't know, Tennessee is going to be doing the NAPS. And that gets sorted out.
Yes.
So we're completely
waiting for the attorneys.
We're completely conflicted, but anyway. And it has been really interesting catching up with Marion, because I think all of us wonder what it must be like to be working in healthcare systems in the States at the moment. So it is nice to get to put how difficult it is actually in the States in terms of their health system structures compared to what we work with. And so Marion's quite well connected to sort of the key stakeholders and has some really innovative ideas. And the difference between the States and Australia, I think, is that access to the sort of data, some data, not all data, but some data and the volume of data that we don't have here. So there are some interesting perspectives that you have in what you do.
Thank you. And thank you for coming yet again at lunchtime. Okay, so I'm going to be talking on combating antimicrobial resistance challenges and opportunities with a predominant focus on antimicrobial stewardship. Okay, and I really want to acknowledge some of my team members. I'm very fortunate to have two pharmacists on my team. One is ID trained. I have an epidemiologist who exclusively looks at antimicrobial stewardship data, as well as Pam Cowley, who's my deputy. And then at CDC, Adam Srinivas and Laurie Hicks have also provided some of the slides, and then the CDC leadership group on antimicrobial stewardship. So I'm going to talk a little bit on the drivers for antimicrobial stewardship in the United States, describe a little bit about the CDC core elements of antimicrobial stewardship, reporting to the NHSN, that's the National Healthcare Safety Network Antimicrobial Use Module, briefly look at regional versus state antibiograms, briefly touch on the AR Surveillance Task Force recommendations, specifically on the suppression of data. And then I'm going to be focusing predominantly on acute care with a little bit of long-term care. I'm not going to be addressing community antimicrobial stewardship. So there's been a really significant national momentum of antimicrobial resistance, which really started with the CDC Antimicrobial Resistance Threat Report, which was taken and read by President Obama and Michelle Obama. And they were the ones which wanted to find out more about antimicrobial resistance and antimicrobial stewardship. They wanted to have some action on it. And that really is, so it was data that prompted all this attention on antimicrobial resistance at the time. And the threat report is going to be updated again this year. It's going to be coming out in 2019. This then led to the PCAST report, the Antimicrobial Resistance Solutions Initiative, and National Action Plan, the White House Antimicrobial Stewardship Forum, and the Presidential Advisory Council on CARB. So I had the privilege of serving on the Antimicrobial Resistance Workgroup for PCAST, the President's Council for Advisors on Science and Technology, and we had made several recommendations. These were the broad recommendations which we made. Number 6 was improving antimicrobial stewardship of existing antibiotics in healthcare. And we specifically stated that we wanted to have certain drivers behind that, and that is CMS, the Centers for Medicare and Medicaid Services, which is a very big payer in the United States, to use reimbursement incentives to drive antibiotic stewardship. And so when you're using these incentives for CMS, even though not all the patients are covered by CMS, the impact of basically every hospital looks after CMS patients. And they don't separate out. These patients get antimicrobial stewardship and these ones don't. So once you have this requirement, it's a global requirement. And so we asked that there were stewardship programs in hospitals and long-term care facilities be established, that we have antibiotic use in the outpatient setting, and to gather data on antimicrobial use and resistance to the National Healthcare Safety Network. So those were our recommendations. President Obama issued the executive order on combating antimicrobial resistant bacteria. And within that, it had, by the end of calendar year 2016, to review existing regulations and propose new regulations. And some of these managed to get through before the change in administration. So the long-term care facility regulations went through. The ones for acute care hospitals did not get through and are now stuck in regulatory purgatory. So there was the National Action Plan to combat antimicrobial resistant bacteria. In that National Action Plan, there are 5 major goals, and that National Action Plan is under review. It is currently going to be updated for 2020 to 2025, and I've had the opportunity of providing feedback to that particular group, wearing multiple different hats: the Tennessee Department of Health hat, the Council of State and Territorial Epidemiologists hat, the Antimicrobial Resistance Surveillance Task Force hat, and the Society for Healthcare Epidemiology of America hat. So we've been all providing input into what is the new National Action Plan, because the National Action Plan drives everything else going forward. So under that goal is to implement public health programs and reporting policies that advance antibiotic resistance, prevention, and foster antibiotic stewardship in healthcare settings and in the community. And one of the major things which came out of that were the CDC core elements of antibiotic stewardship. And these ones are the ones which they said there had to be leadership commitment, a single leader who was responsible for outcomes, single pharmacy leader, antibiotic use tracking, regular reporting on antibiotic use and resistance, education of providers on use and resistance, and specific improvement in interventions. And then CDC, following the Hollywood example, you have these, number 2, number 3, number 4. We then decided to go and have one also for long-term care facilities, for the outpatient setting, for small and critical access hospitals. So there are multiple core elements, and they're all available on CDC's website. Now, what's been really great is that in the absence of having regulations requiring the adoption of this, that there are several other groups in the United States which have adopted these core elements. And that one of those is the Joint Commission, used to be called JCO, which is the major accrediting body for most of the hospitals in the US. DNV is a similar group, to the Joint Commission. The CMS-funded Hospital Improvement Innovation Networks, which we work with our hospital association, the industry group, also has taken it up, and ARC, the Agency for Healthcare Research and Quality, Comprehensive Unit-Based Safety Program, the CASP program, which you may know from CLABSIs, also took on these took on CDC's core elements. The Leapfrog group is also proposing to add these questions on the annual survey, and the importance about the Leapfrog group is that this is that the CEOs of hospitals pay particular attention to the Leapfrog group, and so that's an important driver there. We also have a lot of the health insurers who are now looking into this. Anthem, Blue Cross Blue Shield, inside hospital incentive programs are also looking at that. So we have multiple areas all singing off the one song sheet, all wanting to promote the uptake of these core elements. So this is data for 2017. Traditionally, CDC captures the data by an annual survey, which requires to be completed between January and complete by the end of February for the preceding year. So we are going to be, at the end of February, we will have the data for what has happened for calendar year 2018. And here you can see the darker the blue is, the larger the proportion of hospitals is that have adopted all 7 core elements. And Tennessee is right here, and we're really bummed because we're at 84% and the top quartile is greater than 84%. We always seem to be just hitting it below that quartile. This is a progression nationally. Back in 2014, only 40.9% of hospitals met all 7 core elements, but by 2017, 76.4% had met all core elements. Not surprisingly, critical access hospitals had the lowest proportion, only 57.8% met all core elements, versus the general acute care hospitals at 81.9%, and the children's hospitals were leading the pack at 86%. Not surprisingly, larger hospitals had a better adoption than smaller hospitals, and major teaching hospitals more than non-teaching hospitals. This is the data from Tennessee. We're a very long, thin state, and we have significant regional variation with regards to our general communicable diseases. We have marked variation in our uptake of antimicrobial stewardship programs, as well as variation in our resistance patterns. You can see in Northeast Tennessee, back in 2014, only 10% of hospitals had met all the 7 core elements. Yes?
It's just the definition of stewardship is very broad in terms of what people actually do. It can be relatively rudimentary. We know that our accreditation can tick the box with very little. So what is defined as, what did they have to answer to say that? So
CDC had a series of questions which they had to answer, and I'll get to that in a little while. If you just bear with me just a moment, but it's a good question. But so we had really very significant changes, very significant regional variation, but we're going from 10% to 83% uptake of these antimicrobial stewardship recommendations, in terms of these are all based on the 7 CDC core elements, and there's a mapping of certain questions to that particular thing. So this is tracking, these are the 7 core elements, but broad groupings, the progression over time, how we have been improving. And then the NQF put out the National Quality Partners Playbook of Antibiotic Stewardship in Acute Care, which listed a whole ways of methods of how one could meet every single one of those 7 core elements. And we wanted to get greater understanding of exactly what the stewardship programs looked like. And so we basically took all the questions and all the interventions that the NQF playbook had, and we put those out to all of our hospitals and mapped them and wanted to find out exactly what their stewardship program looked like. So we got a lot more granularity through that than through the CDC survey, which had far, far fewer questions. So this here is the 2016 NHSN survey shown in blue. In orange is the survey which we did, which is more detailed. Note that the time differential, the 2016 survey was completed in February versus our survey was done in June, July. So it's a little bit later. The group of people completing the survey is quite different. The NHSN survey is usually completed by infection preventionists, and we had told them, pay attention, speak to your pharmacist as to what your activities are in order to answer the questions, but that may not have been perfect. Versus the survey which we did, it specifically targeted every single pharmacist who's responsible for antimicrobial stewardship within the facility. So we got slightly different time periods and a different respondent. So we believe that we probably have better data because of the groups that we targeted. So you notice here the biggest difference is in the education component from the NHSN survey versus our survey. So we did some digging down, and lots of the facilities didn't get credit for some of these educational activities that they had done. And that's probably because it was the infection preventionist answering it rather than the pharmacist. But it's actually pretty crude what the core elements require. You only need to check one of these boxes to go and get the check for education. But this is the proportion of facilities that answered yes to any one of these activities from the NQF playbook. So we got an idea of what this actually consisted of. And so we did this for every single one of those 7 core elements. And when we provided the facilities back with an individual facility report, where we basically said, this is what you said under NHSN, whether you met it or not, and this is what it mapped to for us. And then we stated, your facility is currently actively implementing in development that's in the 6 to 12 month time frame, or not implemented, not doing that. And we did it for every single one of those core elements. NQF activities, which you could go and do. And then we provided the data of how many facilities, what proportion of facilities in Tennessee did that, so that we could then match up facilities with, hang on, I want to go and do this kind of activity. Which Tennessee facility has implemented this? So we could go and match them up and provide them with advice. And we have bi-monthly antimicrobial stewardship course where we share best practices across facilities. And so this has been a really helpful resource for that as well. So here's another one. Your facility has developed guidelines for the following. And then I had shown this slide yesterday, and what's concerning to us in Tennessee, where we have a major problem with MRSA, is that only 26% of our hospitals at that time had a guideline on the management of Staph aureus bacteremia, which is a real problem when you have such a high morbidity and mortality associated with it, and it's something which we're actively addressing. So CDC is currently proposing new questions or domains for 2019. And that includes having greater granularity on the details on support provided by leadership, such as IT support, communicating with staff and supporting training, actual details on the composition of the stewardship committee, the details on the program leaders, the time allocated and the time spent on that, details on prior authorization and post-prescription review and which drugs, and details of engagement and support of other groups to whom that reports. So they're going into some greater granularity than previously. Now, as I had mentioned to you, there was this executive order that President Obama had signed. He wanted to have monitoring improvements in antimicrobial use through NHSN. So NHSN is a national healthcare safety network. It's a web-based massive database through which all our healthcare-associated infections across all facilities are reported. There's something like 20,000 facilities that report to NHSN. In terms of acute care hospitals, you've got nursing homes, you've got dialysis facilities, ambulatory surgical centers. So it's a massive, massive database. And we wanted to have people reporting to the antimicrobial use module within NHSN. And this is what the original regulations looked like, and they had the conditions of participation. And these are the ones which are currently in regulatory purgatory. A critically important part in the US is this meaningful use piece, which is an incentive to hospital information technology vendors to include reporting to the antibiotic use option as part of their systems. We had very much a chicken and the egg issue. This reporting to the NHSN antimicrobial use module is all automated. It's all using purely electronic means of capturing data from the electronic medication administration record, combining that with ADT, admission, discharge, transfer data, doing some manipulation, and then sending that electronically to the NHSN module. And if you don't have a demand of hospitals wanting to use that module, you're not going to have vendors to go and do it, and the vendor, and vice versa. And the hospitals aren't going to do it if the vendors don't have the technology to be able to accomplish this. And so this provided some incentive for hospital information technology vendors to include this reporting to the antibiotic use option. So this is the percentage of hospitals that are reporting to NHSN antimicrobial use option. In Tennessee, we have had 28 facilities that have reported at least 1 month of data. They're from 17 counties. The average bedside is 221, a median of 157. We had even a small hospital of 12 beds only reporting. They're part of a larger healthcare system, which had initiated the reporting for them as part of that system. And 39% of those are teaching hospitals, and 64% of those are major teaching hospitals. Now, in order for us to go and incentivize our hospitals to report to the NHSN antimicrobial use module, the people who had to really drive this are the pharmacists within those facilities. And so what we have told them is 2 pharmacists from each facility will get reimbursed for training in antimicrobial stewardship, certificate training, either through MAD-ID or through the Society for Infectious Diseases pharmacists, or attending the SHEA antimicrobial stewardship course. And so that's a value of about $1,500 US per facility. As soon as we see your data in NHSN that you are reporting it. So we are now incentivizing the people who have to do all the heavy lifting in order to go and reward them for getting greater education in antimicrobial stewardship. And this has proved to be extraordinarily popular. You know, I could just see the pharmacist's eyes just light up when I saw this, because these certificate programs, they do not normally get reimbursed by their facility at all. This would normally come out of their own pocket. And so this is a way for us to go and incentivize them, rather than us giving a bucket of money to hospital administration, where it gets lost among everything else, and the people who have to do the heavy lifting never see any benefit of that. So this is a very targeted approach that we're using. One of the other things is that we have had, we were actually approached at the end of January last year by several hospitals saying, you know, we have been trying to get hospital leadership to go and invest in this, but since there's regulatory purgatory, we do not have a deadline by which we need to submit data to NHSN. We have tried convincing hospital administration. They will not purchase anything because there's no mandate. Tennessee Health Department, can you please give us a mandate so that we can go and convince hospital administration to go and do that? And so this then was discussed at our multidisciplinary advisory group on healthcare-associated infections. We have an antimicrobial stewardship subcommittee of that has lots of stakeholders. It was deferred to them, and that we then had a subcommittee formed, a work group to discuss this. And we had representatives from reporting facilities as well as non-reporting facilities, the health department, and the industry group at Tennessee Hospital Association. Now, of note, we in Tennessee have an excellent relationship with the Hospital Association, in contrast to many states where there is an absolute fight between the Hospital Association and the Health Department, that the Hospital Association very frequently opposes any kind of mandated reporting that the Health Department puts forward. But we brought them on board. We knew that they were a really critical partner, stakeholder, so we brought them on board. The work group met in June and July. We described what the benefits were for reporting for the participating hospitals, and they had shown how helpful it was in informing the antimicrobial stewardship program and in prioritizing those. And then we described what are the barriers faced by the non-reporters. We developed a timeline for reporting, and then we announced this in the Commissioner's letter in November of 2018. So the Commissioner for Health is a politically appointed person, so the governor appoints them. So it would be probably similar to the local Minister for Health in Victoria. So that's like the equivalent status. So this was in the Commissioner's letter in November, reporting antibiotic use in acute care hospitals through the National Healthcare Safety Network's antibiotic use and resistance module will be required beginning in January 1st, 2021. It'll be a phased-in approach based on hospitals' bed size, and we're advising of this future requirements several years in advance to allow adequate preparation. Because it takes, the minimum amount of time it takes is 6 months from the time that you decide to go and do this reporting, by the time that you gather the data up, execute your contract, and then validate the data going to the NHS antimicrobial use module. By far the shortest amount of time is 6 months. We have to have facilities that have taken 18 months. So we wanted to make sure that people had sufficient time to go and meet this requirement. And this was one of the reasons why the Hospital Association also supported us, because we said that we wanted to go and provide sufficient time, and that this was a phased-in approach based on bed size. So hospitals with bed size of greater than 250, they have to report by January 1st of 2021. We hope that they report earlier. There's nothing to prevent them from reporting early. We already have hospitals reporting voluntarily, but they have to report by this timeline, and then it goes down the different sizes of hospitals. Okay. So this now is a graphic showing our data from our hospitals which are reporting to the NHS and antimicrobial use module. And this is so completely different to what you're finding here in Australia. The most common antibiotic prescribed is vancomycin at 90 days of therapy per 1,000 days present. The second most common is ceftriaxone at 69, piperacillin tazobactam at 64. And then you're getting down to cell. And looking at the data reported by all of you in Australia, it is so very, very, very different over in the US compared to Australia. We then calculated sort of like what the EMS regional rates are. So we combined the numerator data and the denominator data across the hospitals, across these 8 EMS regions. These are emergency medical services regions. And for some of those regions where you see NA, we don't have a single hospital reporting from those yet, so we don't have any data there. But you can see that we have this Northeast Tennessee, tons of antimicrobial usage. They didn't have a strong antimicrobial stewardship program early on in 2014, although they are improving. And they have also been a hotbed for carbapenemase producing Enterobacteriaceae, particular KPCs, Klebsiellas in the past. So very, very marked regional variation.
Is that primarily a rural regional area?
Yes. Yep. So it's really like six largest city in Tennessee. So largest city is in Memphis. The next one is in the Nashville area, which is in the Mid-Cumberland region there. Then it would be Chattanooga, which is down here. Then Knoxville, which is there. And then we've got Jackson in West Tennessee, and then Johnson City up in the northeast. So these are 6 largest. And they have 2 large healthcare systems which have recently merged. What I have to give them enormous credit for is the hospital leadership from those 2 healthcare systems. When we had shown them the data of how many, that only 10% of them had core elements, they specifically organized themselves a dinner presentation for antimicrobial stewardship, for which there were 300 attendees, for which I was invited to present those data. And then they had a forum on antimicrobial stewardship, an all-day forum on a Saturday. And so the hospital leadership really took this to heart. And so you can see this, I showed you previously the tremendous difference in the core element uptake. And I think that illustrates how critically important engagement of hospital leadership is, because they really make things work. This shows the enormous variation in our facilities in Tennessee in terms of looking at raw data of days of therapy. In blue are the antibacterials, in the yellow are the antifungals, and in red are the anti-influenza medications. And you know, the scale is such that you really can only see this for the antibacterials, but enormous variation across Tennessee. Now, CDC has been using a metric called the Standardized Antibiotic Administration Ratio, and it has been working really hard to refine this and to improve the data underneath that. So the SAR expresses the observed to the predicted antibiotic use, where use is predicted based on data being submitted, and then they produce models based on facility characteristics. Of note, this at the present time does not take into account data reported to the antimicrobial resistance module. So, because you actually have less hospitals reporting to the AR module compared to the antimicrobial use module. So you do not know what your antibiogram looks like. You don't know the prevalence of organisms such as MRSA, for example, which could be a major driver of the use of vancomycin. So those are currently not in the risk adjustment model, although that is something that is being considered in the future. So they have now, CDC has done a re-baselining and constructing new metrics for the SAR in 2017. It has now looks at different groups of antibiotics. It now has SARs for both adults and as well for pediatric locations. They now have ICU locations and non-ICU locations, as well as step-down units and hematology oncology units. So the baseline for the 2014 SAR model was based on 77 acute care hospitals with 350 adult and 33 pediatric locations. The 2017 baseline SAR models was based on 449 acute care hospitals, 2,156 locations, and a pediatric model on 109 acute care hospitals at 170 locations. And so now you had these new locations being enabled within the SAR. So the step-down units is also SAR for antifungals. There's a SAR for agents posing the highest risk for C. difficile. They added an azithromycin SAR for pediatrics.
How do they set predicted?
They look at the facilities that have reported in it. That's how it's being predicted.
So it could still be over.
Correct. So in contrast, this is very different to the standardized infection ratio for healthcare associated infections, where you want to go as low as possible, where you want to go to zero. Here, what they have is across all the facilities that are reporting, you're going to have an SR of 1. And then you see in comparison.
I think that's what the UK are doing with their, they've got an online tool which looks like that.
Yeah. I don't know the details of the UK model. Yeah. And it's predicted based on facility characteristics. So not on facility characteristics, patient populations, which are based in the US, the National Healthcare Safety Network. It goes by patient locations rather than service. So you would have, this is a medical ward or a med-surg ward or an orthopedic ward rather than a service. And there are specific definitions in terms of what proportion of patients are within that particular unit, and that is what it gets counted as. And that is what is used for risk adjustment for healthcare associated infections, and they're doing exactly the same thing here as well. And so here you've got 25 adult SARs now for 2017. You've got 15 pediatric SARs which are available. And then here are in Tennessee, this is a snapshot of, so here what we have is, we have different SARs in Tennessee. Blue shows the proportion of hospitals that have a SAR of less than 1. And gray shows the proportion of Tennessee facilities that have a SAR of greater than 1 for that particular SAR value. You can see we've got a lot of gray there. But we have, when we go and do a drill down, we actually, for our heme-onc units, you can see, so this is adult broad spectrum community associated, so this is broad spectrum antibiotics used for community associated infections. These are broad spectrum antibiotics used for hospital onset infections or healthcare acquired infections. These are ones which promote antibiotics which are associated with C. diff, such as your third generation cephalosporins and your fluoroquinolones. This is for your gram-positive, this is like your vancomycin usage. You can see there's not that much grey for our heme-onc units. But when you look at our step-down units in Tennessee, we see a lot of grey. So in our step-down units in Tennessee, we are using a lot more antibiotics than would have been predicted. And so this now gives us an idea of, within hospital locations, what maybe we want to go and drill down to further to go and do an assessment of the appropriateness of that. So this helps as a way of prioritizing where do we have common themes across. This shows our Tennessee facilities that are reporting to the NHSN antimicrobial use module. This is, they had to be reporting both in 2017, which is shown in blue, in red is 2018, and then we showed bed size across the top. So we've got itty bitty hospitals, and shows what their standardized, what their SAR was in 2017 versus 2018. And so if you have the blue on top and the red down at the bottom, that means you have had a reduction in the SAR between those years across. Now, I've been talking about the AU module. So this is looking at antimicrobial usage. There is no component of assessing the appropriateness piece. That is a gap which we're hoping to fill in with MAPS. Now, for the antimicrobial resistance option, we have 21 facilities that have reported at least one event from 13 counties. This is the distribution of our facilities that have reported data. And then the data comes as each antibiotic is listed. Each organism and antibiotic is a single row, so we had a lot of data manipulation which needed to be performed in order to go and look at this. And we used WhoNet to go and perform the analysis, and we created antibiograms stratified by our 8 EMS regions, the isolate source, inpatient versus outpatient, specific unit types, the time periods, etc. Because we heard very strongly from our predominantly from our community providers that they wanted to have a reliable antibiogram that they could go and use to inform empiric antimicrobial choices. And so we wanted to see if there was a way that we could use these data reported to NHSN to create a statewide or a regional antibiogram. So we had 21 hospitals which were from 4 EMS regions, and within that relatively short time period, we already had 48,917 isolates, for which there is the susceptibility profile available. It includes urine, blood, and respiratory isolates, 22 gram-negative rods, 6 gram-positive cocci, and 2 candidas against 4 antibiotics, and 70% were from the emergency department, 14% from inpatient wards, 9% from critical care, and 6% from other locations such as the step-down units. So that's sort of like the makeup of those particular isolates. And so one can create, there's a massive antibiogram on a statewide basis if you want to, you can go and divide this up into whichever areas which we want to. And so we looked at just some specific organisms. So we looked at urinary E. coli, as we hypothesized that the ones from the ED should be a lot more susceptible than the ones from the inpatient units, and that's actually what we show here as well. And then we knew what the distribution is of the numerator data for carbapenemase producing CRE, where in the northeast of Tennessee, we had CP-CRE, which were predominantly Klebsiellas, and we versus middle and West Tennessee. In the middle and West Tennessee area, we had predominantly Enterobacters. And so we were curious as to whether that is based on numerator data. What about now when we look at denominator data? When we're looking at the proportions of these, do we see that actually being reflected there? It is actually also reflected there, because people have been proposing using antibiograms as a method to perform surveillance for resistant organisms rather than getting the individual numerator data itself. So we showed that there was significant geographic variation. And here you can see we are finalizing our data for 2018, but this is for 2017. Here's Johnson City up in the northeast. It is predominantly Klebsiellas where we see, which is carbapenemase producing, versus in the Memphis area, it's predominantly Enterobacters, versus it's more evenly distributed in the Nashville area. In 2016, it was actually completely evenly distributed between Klebsiellas, E. coli, and Enterobacters, and now the Klebsiellas have been taking off. So this really suggests to us that if we really want to create regional antibiograms rather than statewide antibiograms, but there's a note of caution here. And so here as part of the Emerging Infections Program, we also do very, very careful laboratory-based, population-based surveillance. So when we do that, we want to be entirely sure that we capture every single isolate from every resident in that area. So we need to track down, where do patients go, which hospitals do they go to, which laboratories do they go to, our outpatient providers, which laboratories are used for sending the isolates, so that we really get a good sense of what is the true incidence of a resistant organism. So we were looking at the ESBLs, and because this isn't published data and I haven't gotten permission from the other states, those are called states A, B, C, and D. But you can see the number of incident cases and in the population. And in Tennessee, our incidence of ESBLs is a whopping over 400 per 100,000 in comparison to state B, which is 46, and compared to the total average, which is 163. And this is really important because it's a major driver of antimicrobial usage when you've got ESBLs. So this is our catchment area. Nashville is located at the tip of a red arrow. And I couldn't convince any of our hospital laboratories in the Nashville area to go and send me every isolate and report every isolate of ESBLs because the volume was humongous. So we went to a regional hospital and which has a major laboratory that actually serves the hospitals in those other surrounding counties. And they actually also have a commercial laboratory that serves basically most of the outpatient providers. So we didn't have to recruit many laboratories to go and examine that. So we believe that we have really good case ascertainment. We spent 7 months working out what our catchment area was going to be in order to ensure that we were going to get really, really accurate data. So we knew we had a problem with ESBLs in this particular area. Now, when we did characterization of those isolates, the vast majority of them are ST131, so we had 76% of those, and the vast majority of those are resistant to ciprofloxacin. So you don't now have many therapeutic options available from it. And we found that when we did a presentation to the hospitalists, the chief medical officer from that region said, our clinicians are throwing their hands up in the air. They don't have any oral antibiotics to go and treat these urinary tract infections. So if it's an ST131, 91.3% of those were also resistant to Cipro. And so when we then looked at our data in the NHSN antimicrobial resistance module, we thought, okay, do we have a problem only in this area which we did the surveillance in, or is this something which is a problem across Tennessee? So we thought, okay, we have actually data from that particular region. Let's look at the proportion of ESBLs in that region. And it appeared that that region actually had the lowest proportion of ESBLs. So thinking, okay, I can't really believe that we have such a high incidence of ESBLs, and yet our data reported to the antimicrobial resistance module suggests that they have a very low proportion of that. So we looked into it to a greater extent, and I had mentioned this issue when in one of my previous presentations, and it's all due to data suppression. So the data that goes into the antimicrobial resistance module is the data from a laboratory information system. And not all the data from the susceptibility testing instrument goes into the laboratory information system. And so they actually suppressed those, or they suppressed all indication that this was an ESBL because they didn't want to show those antibiotics to the clinicians. And that is the reason why these data didn't show up. So that is a big word of caution. You really need to understand exactly where the data come from. Has there been any data suppression along the way? So one of the other things that I'm involved in is the Antimicrobial Resistance Surveillance Task Force, which aims to go and address some of these particular issues. And there's a reference here. It'd be worthwhile having a look at what those findings are. There's still additional work groups currently underway to address some of these issues. But this is one of the topics of data suppression. If we really need to gather more information on the reasons surrounding data suppression of susceptibility data, why those data are suppressed, and when it might be helpful or not, to really understand that to a greater extent. And then to develop guidance for laboratories on how to approach the suppression of data. So we are now also working with commercial susceptibility testing instrument manufacturers. So we're currently working with bioMérieux, and we'll be working with the other ones in order to find a way of how can we ensure that public health, infection control, and antimicrobial stewardship champions at those hospitals get access to all the data that they need. And don't just get a subset of the data, which is for the other clinicians. So we're actively working on that right now. And so here in the sort of greenish tone, you've got the other topics which are covered in the Antimicrobial Resistance Surveillance Task Force report. Then just as a reference for you, the CDC Patient Safety Atlas, it's had quite much of an overhaul. It has some data on inpatient antibiotic stewardship data. Those are the CDC core elements. It has outpatient antibiotic use data from 2011 through 2015. It also has the national and state HAI program reports. So this has the CLABSIs, the CALDIs, etc., MRSA rates for nationally and for each individual state. And it also has some antimicrobial resistance data. That antimicrobial resistance data at the present time reflects the susceptibility profile for those organisms which were entered into NHSN because those are the organisms causing a healthcare associated infection. So it is only a small window in what the problem is of antimicrobial resistance. It's only for healthcare associated infections. If it's not a healthcare associated infections, those data are currently not reflected in there. But I would be expecting CDC to report the data from the NHSN antimicrobial use module and the antimicrobial resistance module in the future into here. So now I'm going to go briefly discuss a little few things about long-term care. The timing was such that the regulations for nursing homes actually did pass through with sufficient window of time before the change of administration. And this these CMS conditions of participation have been an absolute total game changer with regards to infection control as well as antimicrobial stewardship in our long-term care facilities. We have very actively tried to engage with our nursing homes, but they always had additional prioritizations. Now that this is a requirement, they are welcoming us with open arms. They really are wanting our help in assisting them with work on things. So it just shows that that those drivers are critically important in getting the appropriate engagement. Now, you're probably familiar with the NQF playbook for acute care hospitals. You may not be familiar with this playbook. This is for nursing homes. For reasons that I do not understand, there's a cost associated with this one, and there isn't for the hospitals. So it's actually a really good document to go and look at, and we're currently trying to get some funding to purchase these for every single one of our nursing homes so that we do not have this as a barrier. But it's actually really nicely put together, and it approaches the approach is organized by resource intensive. So they have low resource intensive approaches as well as high resource intensive approaches. So as in Tennessee, we have been providing visits, tiptoeing into our nursing homes, trying to get some data on antimicrobial usage, and there's a requirement of one of the core elements that you had to track and report these core elements. And so what we're currently doing is we're asking facilities to report antimicrobial use data to a REDCap database on a monthly basis. And the metric is the number of residents with receipt of specific antibiotics over a 24-hour period over facility census. And we provide quarterly reports on the facility level as well as on the collaborative. So far, we only have a very modest uptake at the moment. We only have 11 facilities reporting to us. But over we started off with 7 facilities, and over a 1-year period, we went up to 11 facilities. This is the average daily census by the facilities. So we've got really significant variation in that, ranging from 14 to 172. And then we divide up the proportion of patients on antimicrobials, and we divide them, so the total bar shows the total number of people on antibiotics, but we show which proportion were initiated in the facility and which one did patients come in from outside, because that really allows us, the interventions are going to be very different accordingly. And so splitting the data up this way shows, again, the enormous variation between these different facilities. And this is now, we then divided the antimicrobials out by category, like antibiotics used predominantly for C. diff or for treating of respiratory disease, for skin soft tissue infection, or for urinary tract infection. And this is just across those 11 facilities, what proportion of patients are receiving those antibiotics. And this is like a facility report, which one would get collaborative wide is in red, and this is for an in particular individual facility, just as an example. So I'm going to go and stop here and see if anybody has any questions.
Do you think antibiotics should be made available to clinicians? We don't. We have moved away from that practice completely. And even it's Sanford is a disaster. To the broad spectrum of stuff. It actually drives an appropriate response.
In the US, we do not have a therapeutic guidelines. We have every professional organization puts out their own guidelines.